Merhabalar,
Hello, thank you. My is to speak on schizophrenia and OCD. To have a look, first of all, in schizophrenia and psychotic diseases, OCD as a diagnosable disease. Also, even if it's not diagnosed, OC symptoms are seen a lot. We will speak about they are more resistant to therapy and they are more severe. Recognize and diagnosing these diseases and symptoms are not so straightforward or easy. Then we will be speaking about how challenging the treatment is. In recent few years, there was a meta-analysis. 43 studies had been looked. Generally, 4,000 patients' data had been collected. Despite that there are different thresholds in different diseases, there are the patients and the symptoms have been discussed who had been diagnosed as OCD or with the OCS. The OCD prevalence was around 12 to 13% comorbidity in schizophrenic patients, and symptoms are even more widespread, around 30%. And when I saw the paper, it was more or less inconsistent with my clinical experience in schizophrenic diseases. OCD is very frequently seen. Also, the antipsychotics might have an effect. We will also discuss this. This is from 2014, but most of the studies which is known today are mostly encompassed by this, including one of our studies. And since 2014, I think we don't have a new and serious study, so I think this prevalence data are reasonable. For anybody who is working schizophrenia clinic can be witnessing on a daily basis the comorbidity between OCD and schizophrenia. I said that they might be more severe patients or therapy-resistant patients, but evidence base is small because we don't have very rigorous and comprehensive studies on this. But as an anecdote and also as case series and case reports, sometimes it's called schizo-obsessive. The patients who can be both diagnosed with OCD and schizophrenia, and we know that their results are bad in society, even in comparison with schizophrenic patients, and they can give different responses to different therapies. The first line antipsychotics, such as hallucinogens, are not used a lot because they don't have serotonergical effects. They are not being used generally very widespread, but still these patients can display more severe adverse effects. But we cannot say that the second line antipsychotics are so valuable in contributing to this. Shortly, the second line the antipsychotics might have a double effect on schizophrenia patients. Some of them improve, some of them worsens. So this literature is too complicated. Even Risperdal, double-line randomized placebo-controlled, the gold standard study. But when you think that Risperdal is good for OCD, and when you see that you are giving Risperdal to a schizophrenia patients and OCD is emerging, don't be surprised, because you cannot say that this antipsychotic is good for OCD or not, because there is a double way effect, and I will discuss it at the end. When we go into details of therapy, treatment, when we bring them together, all literature bring them together, we see that olanzapine might be more effective, especially in comparison with risperidone and clozapine for schizo-obsessive patients. Ariprazole has shown in a similar way a meaningful clinical improvement, both case reports and trials. But generally, anti-obsessional agents, SSRIs, clinical medicines should be thought more in the details. The first line or the first step medicines used in OCD, we have to use them in also schizophrenic patients. Also CTT, cognitive behavioral therapy, and other things can be used. I will discussing it. And one of the very important issues is the clinician should know the problem so that he can understand in a timely manner and in a right manner. And it's not easy always, because psychotic syndromes and OCD symptoms are overlapping widely, and we don't have a simple thumb of rule about this overlapping. We should look at the big picture and we should use our judgment. I will, if you go into details of the diagnosis, of course, many patients have more classical symptoms such as delusions and very classic obsessive symptoms, but in some patients, really we might see some mixed symptoms. For example, while the severity and chronicity of obsessive syndrome symptoms go up, they lose their insight and they begin to believe in their obsession. And or from the other side, sometimes delusional patients begin to go into obsessive thinking patterns and even ritual movements coming from delusion, compulsive-like syndromes. On one hand, we can say that sometimes the patient is starting from one side but moving towards the medium or the midpoint. It was written a lot in old versions of DSM-3. Patient, if she is aware of that, she doesn't want this symptom, it's called obsession. But if doesn't be aware of it, then it's delusion. But sometimes, and it was understood that it was not overlapping with clinical truth. In DSM-5 and 4, there were still some symptoms which lost its insight feature, but still they were obsessions. It's not as simple as saying, I don't want to wash my hands, I know there is no microbe, but still I wash my hands. And another patient who says that somebody is taking my photos and recording my voices from outside. We see a simple difference between these patients, but it's not that easy actually from both delusion side and obsession sides. Also, you can tell this to the clinicians, if this is like this, then it's an obsession, and if this is like this, then it's a delusion. We don't have these criteria. There are some suggestions about this. Kornowski and friends in 2012, even they suggest the criterion. You can look at this paper. I will not go into details because I want to go to the treatment part. But according to Poirovki and colleagues' criteria, it says that we should look at the big picture. Listen to the details of the symptoms. Listening to the patients carefully and observing is not helping us easily to find if it's an obsessive or delusion, but looking the general course and looking at the other symptoms. For example, if a patient is severe, we might be seeing delusion, or we should be able to see an OCD in a routine schizophrenic patient. We should think from where the patient is coming and where she is going. Generally speaking, all repeating thoughts or movements are not OCDs, but if they are clinically meaningful and cannot be controlled by a patient, some thought patterns and rituals might be accepted as OCDs. Of course, this is relevant because when you know it and when you move against it, then you can very seriously improve the life quality of the patient, especially in clozapine. Sometimes you can know a side effect which is caused by you, and you can decrease this impact. So it's very important to know. When we go to pharmacotherapy in schizoobsessive patients, sometimes it's called SOD, schizoobsessive disorder, but generally we think it as a comorbidity between OCD and schizophrenia. I don't think it as a novel disease, but still SOD is used a lot as a term. We don't have very high-grade clinical trials. They don't say that this patient responds to this medicine, etc. We have mostly based on case series, but we have some clinical trials. I will be mentioning them. But as I said, olanzapine apparently is more effective in comparison with the second-line antipsychotic in schizophrenia plus OCD patients. It can treat both OCD and psychotic symptoms, but in some patients it can sometimes worsen the OCD. Olanzapine, we have many case series. Some schizophrenic patients who had been suggested to olanzapine have gone worse, but also clozapine is very consistently worsening OCD. Each clinician should know this. If you see a patient with clozapine, just being careful to TD and other symptoms, we have to be careful about OCD. It's very widespread. 1/4 or 1/3 of clozapine taking patients are displaying OCD or OC symptoms. It's an important detail. Sometimes the other clinicians are missing this. If you see a patient and decrease the clozapine, and if you control the symptoms, actually you will get a lot of respect from patient, and you will be very successful from clinical perspective. Suprazone also have interesting findings. Bimodal, some go, some improve, some worsens. Some OCD patient symptoms goes better, some worsens. Even in the same clinical trial, it was seen that some patients improved, some patients worsened. A study in Germany, actually, this one. Aripiprazole, I talk nice of it, but still in some case series, when some schizophrenic patients had been given aripiprazole, existing OCD symptoms decreased, or also when it's used as an add-on, it was seen that some reduction of OCC after adding aripiprazole to clozapine, olanzapine. But also in some schizophrenic patients there was a correlation between aripiprazole initiation and aggravation of OCS. These were more or less the second-line antipsychotics. I will not go into details because, as I said, based on this literature, it's impossible to start a rational drug treatment because each and every antipsychotic can have different results, but it's impossible to base our decision on clinical history. So if you are to use a second-line antipsychotic, limited efficacy. As a monotherapy in schizo-obsessive patients, it will not help you a lot. Generally, you have to go back to anti-obsessional drugs, SSRIs, tricyclics, the first-line drugs in OCD. Also, we are using them in schizophrenic patients with OCD or OCS. This is an important detail is fluvoxamine and antiopressine interaction. It's sold as Luvox in fluvoxamine, but fluvoxamine is in some ways getting into interaction with Stockholm 450 systems, 450 systems, and it's inhibiting the fluvoxamine activating enzymes. It was a widespread scenario 10 or 15 years ago. You start a clonazepam to a schizophrenic patient. This time you get OCD-like symptoms. Then you start fluvoxamine. Fluvoxamine can double or triple the fluoxetine level in the blood. So your chronic epilepsy, seizure, or other side effects can arise. We generally stop to use fluvoxamine fluoxamine in fluoxamine patients, because there are many other options. We don't need to take risks. There is a small literature, very interesting, but on this, after antipsychotic, instead of anti-obsessives, we can give mood stabilizers, especially valproic acid and obsessin, valproic acid or lamotrigine. One from Turkey, I don't know which center, which site. I don't have much experience about this, but a small number of patients had been given some work, and still interesting. These are not first-liners in OCD, I mean the valproic acid and lamotrigine, but in schizophrenic OCD patients it was found to be effective. When we speak about ECT, despite that it's not thought for OCD, but in schizophrenic patients there are certain case reports where it is used. In our center we actually tried this acute psychosis resisting therapy. Sometimes ECT can be effective. It's not used very widespread, but if it doesn't work in other way, especially in clinic inpatients, sometimes we have to have recourse to this. And in some schizo-obsessive patients, I saw that ECT worked, but it's generally risky. And of course, we are thinking deep brain stimulation, DBS, for OCD. FDA in states approved this for OCD. Also, RTMS, TDCS, and other brain stimulation techniques are used. They are tried actively in OCD.
In the OCD literature, they are being followed with enthusiasm, but when there is schizophrenia plus OCD, we cannot say that they are being seriously employed. There are some speculations by a couple of writers, like deep brain simulations. If it's working for the OCD, it may also be employed for the schizophrenia patients or treatment-resistant patients, but there are no serious evidence, which means that I do not suggest to anyone. Yes. Finally, this would be my comment. Clinicians should be ready to recognize and treat OCS in patients with schizophrenia. With or without antipsychotic treatment, you should pay attention to the clozapine, for example. But do not depend on the antipsychotic drugs. It may treat one patient, whereas it may worsen another one. This should be paid attention by the clinician. This is patient dependent. It's a clinical problem. Since our evidence basis is not very strong in the external world, there is no strong evidence. Do not be a purist. There is no insight in this patient, which means it's a delusion. We should start antipsychotics. Do not think like that. We're talking about the OCD in the schizophrenia patients. OCD treatment is something different. But if the patient is diagnosed with schizophrenia, and if this diagnosis is well-based, please do not ignore the OCD. Do not ignore this. Do not miss this, because you can create some significant changes in the life quality of the patient. Most patients appear to be on an inverted U-shaped curve. Some get better, some get worse with antipsychotics. For example, if the patient is on this leg of this U, then they go well when you give the drugs. But on the other hand, the other patients go bad when you treat them with the drugs. This is one of the complex aspects of the dopamine system. When you give drugs, you change the balance in the dopamine system. Serotonin receptors balance is also disturbed by the drugs. When you give the drug, the brain of the patient is reacting depending on its location in the U shape, and we can't clearly measure this and identify this. So it's not possible to act rationally. You need to act empirically. That's why the clinician should be very curious. When he identifies the problem, he should treat this, and he should be able to change his or her treatment depending on the reactions. When you look at the literature compared to the olanzapine, these are more secure drugs. But for the most of the patients, you need to opt for the anti-obsessional agents, like the first line in the OCD treatment, such kind of drugs should be paid attention to. There was another slide. CBT, cognitive behavioral therapy. In the OCD, they are as important as the anti-obsessional medicine, even more important. These are the first-line treatment options. In our center, in our hospital, we have an OCD institute. We are visited by 600, 700 obsession patients, and some of them are not even receiving anti-obsessional agents, because we can have some significant improvements with the CBTs. Exposure, expose. I mean, you expose the patients with his or her own obsessions, and they try to oppress these anxieties, so they are going through this anxiety which was unacceptable before. Is it possible to treat the OCD in such kind of patients with schizophrenia? It was discussed a lot, and there weren't so many detailed, serious clinical trials, but there are some case series from the centers that tried this, and they're not very serious. In a schizo-obsessive group of schizo-obsessive patients, if cognitively they are in a good position, it is reported that they reply to the CBT very well. But in majority of the patients, you don't have a very good cognition, and a treatment that is based on the cognition is not responded very well. Schizo OCD patients are sent to the OCD Institute, and we give a try to the CBT, and it is not tolerated by the patients. We can't get good results. So they cannot express themselves to the extent that they can benefit from the CBT. For example, they can't visit us every day, they can't do their homework. That's why I had a final slide about CBT, but then I excluded this. CBT is widely used in the OCD. Clinically, as far as I can see, it is not fruitful to follow CBT for the schizophrenia plus obsession patients.